Hello students. Welcome to Concepts of Care for Patients with Muskuloskeletal Trauma. This is your last chapter in regards of this segment, musculoskeletal, during the semester, right? So this chapter is very long and we have to review all the conditions. So we're gonna do it in a very professional and very deep way. So let's start. The first thing we're going to review is fractures, okay? A fracture is a break or disruption in the continuity of a bone that often affects mobility and causes pain. It can occur anywhere in the body and at any age. The pathophysiology of fractures has the same basic pathophysiology mechanism and requires similar patient care. All of them require similar patient care. The only difference is going to be the location, the extent of the injury, okay, and the type of fracture. Interprofessional collaborative care regardless of fracture type or location. Okay, classification, you have complete fracture is the break when the break is across the entire width of the bone and such a way that the bone is divided into two distinct sections, okay? And if bone alignment is altered or disrupted, the fracture is also referred to as displaced fracture. The ends of bone section of a displaced fracture are more likely to damage surrounding nerves, blood vessels, and other soft tissues. So this is the displaced fracture. Incomplete fracture, the fracture does not divide the bone into two portions because the break is through only part of the bone. Okay, a fracture can also be described by the extent of associated soft tissue damage. It could be open or compound, or closed or simple. So if I refer to a fraction as compound, you understand it's an open fracture, right? The same if I mention a simple fracture, it means it's a closed fracture. The skin surface over the broken bone is disrupted in a compound fracture. The skin surface over the broken bone is disrupted in a compound fracture, means is open, right? Which causes an external wound. And this type of fracture is going to put the patient in a high risk for infection because it's an open wound, right? These fractures are often graded to define the extent of tissue damage. A simple fracture, now we know is a closed fracture, is the same, does not extend through the skin and therefore has no visible wound. And here we have an interesting graphic of different type of fractures. We have the impacted, you can see the comminuted, which is means that the bone is broken into multiple pieces, we can see here. And then we have the displaced spiral and the displaced transverse. Okay, so let's continue. A fragility fracture, also known as a pathologic or spontaneous fractures, occur after minimal trauma to the bone that has been weakened by disease. For example, a patient with bone cancer or osteoporosis can easily have a fragility fracture. The thing is that the trabecular tissue, the one in the middle of the bone, the spongy tissue, right, is weak. So that is causing this type of fracture, the fragility fracture, right? That's why osteoporosis can cause this fragility fracture. And fatigue stress fracture results from excessive strain and stress on the bone. This problem is commonly seen in recreational and professional athletes. Compression fractures are produced by a loading force applied to the long axis of cancel of bone. Okay, so let's continue. Stages of bone healing. Fractures heal in 5 stages. There are continuous process and not single stages. Okay, again, fracture heal in 5 stages that are a continuous process, not a single stages. Okay, so in stage 1, within 24 to 72 hours after an injury, a hematoma forms at the site of the fracture because bone is extremely vascular, right? Stage 2 occurs in 3 days to 2 weeks. Granulation tissue begins to invade the hematoma. This then prompts the formation of fibrocartilage. In stage 3, vascular and cellular proliferation are present, known as a callus, within 3 to 6 weeks. This formation is in that period and is the beginning of a non-bony union. As healing continues, in stage 4, the callus is gradually resorb and transform into bone. The callus is resorbed and transformed into bone. And during the 5th and final stage of healing, consolidation and remodeling of bone continue to meet mechanical demands. So those are the stages of bone healing. In young, healthy adult bone, healing takes about 4 to 6 weeks. Complete healing may take 3 months or longer in people who are older than 70 years old. So one of the concepts that we are going to learn is avascular necrosis, also called osteonecrosis, that can also impact healing. And for that purpose, we're going to watch the following video. Let's see.
Hi, I'm Dr. Courtney Sherman from Mayo Clinic in Jacksonville, Florida, and today we're going to discuss avascular necrosis of the hip, which is a hip disorder that we often see in patients that causes hip pain. There are multiple causes for avascular necrosis. They include idiopathic, which means it just happens and we don't know why. At times, oral steroids like prednisone can cause it. Sometimes alcohol can cause it. At times it runs in families, or there's other genetic or blood disorders that can cause it, such as sickle cell anemia. There are various treatments for it, depending on the level that it is or the stage. There's 4 stages of avascular necrosis, 1 through 4, with 1 demonstrating minimal to no changes on X-ray, but we can often see it on MRI. And then stage 2 and 3 and 4 we can see on X-ray and confirm it on MRI. And as you go through that process of the staging, the disease gets worse and the hip can collapse at stage 4, which leads to a hip replacement. So ideally we like to see patients before they get to stage 4, because if you have collapse of your hip, then the only treatment really is a hip replacement, which can be very successful for patients if need be. So in avascular necrosis in stages 1 and 2, especially, and at times stage 3, we have a new procedure that's minimally invasive in order to regenerate the bone, because in avascular necrosis the bone has deteriorated and partially died. Therefore, we're able to do this minimally invasive procedure where we harvest stem cells from their pelvis. We spin it down in a machine that extracts the stem cells in the operating room, and then we make a small 6 millimeter hole into the bone, and then place the stem cells into the region of bone that has degenerated, with the goal of regenerating the bone in the region and avoiding a hip replacement for the patient. This procedure is relatively new in the United States. It's been done in Europe longer, and the studies have shown that in stages 1 and 2 avascular necrosis, we can save a patient's hip over 80 to 90% of the time with this procedure. So we have also found that same data in our patients at Mayo Clinic and able to save many hips where we would not have previously been able to do so. Patients with avascular necrosis typically present between 20 and 50 years old, although at times can be outside those age ranges, and typically present with hip pain and groin pain. If you have this and it goes on for multiple weeks, you should see a physician and obtain at least a hip X-ray or pelvic X-ray. If that is worrisome for avascular necrosis, then the next study is typically an MRI, and that will confirm the diagnosis. If this does demonstrate avascular necrosis, then it would be best to see an orthopedic surgeon at that point for further evaluation. For more information on this or other orthopedic conditions, please visit mayoclinic.org.
Thank you so much. It was excellent definition, description, and the full course of treatment for avascular necrosis. Especially right now, we know that stem cells are available for this. The effect of age on bone healing. Bone healing is often affected by the aging process. We know that. Bone formation and strength rely on adequate nutrition. We know that. Calcium, phosphorus, vitamin D, and protein are necessary for the production of new bone. So for women, the loss of estrogen after menopause decreases the body ability to form new bone tissue. That's your osteoblast, right? Do you remember? We are just reviewing some concepts with this box here named patient-centered care, older adult health. Chronic diseases can also affect the rate at which bone heals. For instance, peripheral vascular disease, such as arteriosclerosis, mean the narrowing of the arteries, reduce arterial circulation to bone. Thus, the bone receives less oxygen because the pathway is narrow and fewer nutrients, both of which are needed for healing and repair. And that's good to know. Better explain impossible. So this concept here is excellent and is a review summary of many concepts that we learned before. Complications of fractures. It all depends on the type or location of the fracture and several limbs and life-threatening acute or chronic complications can result from the injury, right? So acute complications of fractures, venous thromboembolism, BTE, and bone or soft tissue infection is one. Venous thromboembolism includes deep vein thrombosis, DVT, as I explained during the class. So venous thromboembolism is the umbrella. We have under that umbrella deep vein thrombosis and pulmonary embolism, right? It is the most common complication of lower extremity surgery or trauma and the most often fatal complication of musculoskeletal surgery. Okay, and that's good to know. NCLEX alert, for sure, for sure. So we have here the steps and the stages of bone healing. Feel free to review hematoma formation. Then is going to appear the granulation tissue, the callus formation or callus formation, osteoblastic proliferation, bone remodeling, and bone healing is completed. Now, we have wound infections that are the most common type of infection resulting from orthopedic trauma. They range from superficial skin infections to deep wound abscesses. Infection can also be caused by implanted hardware used to repair a fracture surgically, such as screws, being plates, or rods. Okay, Clostridia infections can result in gas gangrene or tetanus and can prevent the bone from healing properly. So we know Clostridia is a gram-positive bacteria from the family of Clostridium, anaerobic and form spores. So spores are reproductive cell capable of developing into a new individual without fusion with another reproductive cell. So this type of bacteria, they can replicate without having the intervention with another reproductive cell. These are very dangerous. Bone infection or osteomyelitis is most common with open fractures in which tissue integrity is altered and after surgical repair of the fracture. So bone osteomyelitis, right? These infections are common and many result from multi-drug resistant organisms such as methicillin resistant Staphylococcus aureus, MRSA, Reducing MRSA infection is primary desired outcome for all healthcare agencies. Staphylococcus aureus is the terror of the hospitals, nursing homes, really causes too many things, sepsis, septicemia, you name it. Several complications of fractures are rare but are potentially limb or life-threatening. Acute compartment syndrome, this is another concept, is a serious limb-threatening condition in which increased pressure within one or more compartments that contain the muscle, blood vessels, and nerves reduces circulation to the lower leg or forearm. And to understand better the pathophysiology of compartment syndrome, we are going to watch the following video.
The muscles in the body, together with blood vessels and nerves that supply them, are organized into compartments, each of which is encased in a thin but tough membrane called a fascia. For example, the lower leg has 4 muscle compartments: anterior, lateral, superficial posterior, and deep posterior. The function of the fascia is to keep the muscles in place. Its ability to expand is limited. Compartment syndrome develops when excessive swelling or bleeding increases the muscle volume beyond the ability of the fascia to stretch. As a result, pressure within the closed compartment rises, impairing blood flow. Without oxygen and nutrients from the blood, muscle and nerve cells cannot function properly and eventually die. Compartment syndrome occurs most often in the lower leg, especially in the anterior compartment, but it may also happen in the thighs, feet, arms, hands, abdomen, and buttocks. The earliest and also most prominent symptom is pain, which intensifies when muscles are stretched. The muscles can feel tight and swollen. When nerves are affected, patients can feel tingling, burning sensations, as well as numbness and muscle weakness. These are signs that permanent tissue damage has occurred. There are 2 types of compartment syndrome: acute and chronic. Acute compartment syndrome is typically due to a serious injury that results in internal bleeding or swelling, causing compartment pressure to rise rapidly to a dangerous level. Other possible causes include having casts or large bandages that are too tight, use of anabolic steroids that increase muscle size too quickly, and sudden return of blood flow after it was blocked for a long time, such as during a surgery or loss of consciousness. The pain associated with acute compartment syndrome is typically severe, much more than it is expected from the injury alone. Diagnosis is by physical exam, X-ray imaging to detect fractures, and compartment pressure measurement tests. Acute compartment syndrome requires emergency surgery to cut open the fascia to relieve pressure. Chronic compartment syndrome, also known as exertional compartment syndrome, is most commonly caused by muscle exertion, such as overtraining in athletes. Sports that involve repetitive movements, such as running, biking, and swimming, pose a higher risk. People with less flexible fascia are more susceptible than others. The pain typically comes during exercise, intensifies as it continues, but usually resolves within half an hour of rest. Over time, however, symptoms can get worse and take longer to subside. Unlike the acute condition, chronic compartment syndrome is usually not dangerous simply because the pain typically stops people from continuing the causative activities before their nerves and muscles are permanently damaged. Diagnosis is by ruling out other causes and involves physical exam, imaging studies, and compartment pressure measurement tests. X-ray imaging is used to rule out fractures. MRI scans can help evaluate muscle structure and assess fluid volume. Another technique, near-infrared spectroscopy, measures the oxygen saturation level. These tests are non-invasive and are therefore preferred over the invasive compartment pressure testing. The tests are done before and after exercise. Chronic compartment syndrome can be prevented by doing low impact exercise, alternating different types of exercise to avoid repeating the same movements for too long, building endurance slowly, not abruptly, working out on a softer surface, and wearing proper shoes. Anti inflammatory medications and physical therapy may help some patients. However, people who want to return to the offending sport usually need surgery to release the fascia.
Thank you so much. Now you are a master in compartment syndrome. So, we know it's a serious limb-threatening condition in which increased pressure within one or more compartments that contain the muscle, blood vessels, and nerves reduces circulation to the lower leg or forearm, right? And the pathophysiology behind this is that sometimes this pressure can cause ischemia and the edema cycle, right? And we are going to find the presence of histamine by the ischemic muscle tissue, and venous drainage decreases as well. As a result, plasma protein leak into the interstitial fluid space and edema occurs. Edema increases pressure on nerve endings and causes severe pain. If the condition is not treated, cyanosis, tingling, numbness, paresis, and necrosis can occur. That's why it's very important to understand the pathophysiology of compartment syndrome. The pressure to the compartment can be from an external or internal source, but fracture is present in most cases of compartment syndrome. Patients with acute compartment syndrome may need a surgical procedure known as fasciotomy, as the doctor explained in the video. Long-term problems resulting from ACS include infection, persistent motor weakness in the affected extremity. That's why it's very important to assess, to conduct your neurovascular assessment, weakness in the affected extremity, contracture, and myoglobinuria renal failure. Myoglobinuria is the presence of myoglobin in the urine, which is a compound containing a heme molecule similar to hemoglobin. So heme is related to the blood, myoglobin is related to the muscles, right? We usually result from rhabdomyolysis or muscle injury. So rhabdomyolysis is a breakdown of skeletal muscle due to direct or indirect muscle injury. If not treated immediately, it can lead to kidney damage. Okay, and I have added in the supplemental file information from the Cleveland Clinic about rhabdomyolysis. So in extreme cases, amputations becomes necessary when we get to this point in acute compartment syndrome. So key features of acute compartment syndrome, you have the physiologic change versus the clinical finding. Okay, so increased compartment pressure, clinical finding is going to be no change. Increased capillary permeability is going to cause edema. The release of histamine also is going to cause edema. We know that histamine has that effect. Increased blood flow to the area, pulses present, pink tissue, and the list goes on and on. You can read and understand better the whole pathophysiology behind compartment syndrome. Another term, another concept that we need to learn is fat embolism syndrome. We discussed this in previous chapters. I am providing the video in the supplemental file for you to refresh your concepts. This is another serious complication of fractures in which fat globules are released from the yellow bone marrow into the bloodstream within 12 to 48 hours after an injury. So it's basically the first 12 to 2 days this can happen, fat embolism syndrome. And the most common symptom is the petechiae in the chest, right? Among other symptoms, there are a lot, but this is one of the common ones. So fat embolism syndrome usually results from fracture or fracture repair, not only fractures but fracture repair, but may also occur, although less often, in patients experiencing pancreatitis, osteomyelitis, blunt trauma, or sickle cell disease. So here is where most of all the things, most of the concepts we learned so far are getting interconnected. Sickle cells, pancreatitis is coming in the segment of gastrointestinal, osteomyelitis, we have discussed this. The early signs and symptoms of fat embolism syndrome are a low arterial oxygen level, hypoxemia, dyspnea, and tachypnea, which is increased respiration, right? Headache, lethargy, agitation, confusion, decreased level of consciousness in general, seizures and vision changes may follow. Non-palpable red-brown petechiae and macular missile-like rash may appear over the neck, upper arms, and or chest. This rash is a classic manifestation, but it's usually the last sign to develop. Okay, that's why assessment is very important. And all these assessments, all these signs and symptoms are those are good to know. NCLEX alert, okay, is gonna come in your exam. They are gonna ask you questions about fat embolism syndrome, and probably they are going to give you a few choices, and you have to select the choice that contains the most accurate signs and symptoms, right? Abnormal laboratory findings include decreased PaO2 level, often below 60, and the PaO2 is the partial pressure of oxygen in arterial blood. The normal is between 75 and 100, and this means how well oxygen moves from lungs to the blood. That's the partial pressure of oxygen. Then you're going to have increased erythrocyte sedimentation rate, which is a measurement of inflammation, decreased serum calcium levels. And the reason why the serum calcium levels are decreased, remember that when we have a fracture, calcium is going to be released from the bones to the serum. But why are we having decreased serum calcium levels? Is because the calcium is going to bind to the fatty cells. That's why in the laboratory is going to appear as decreased serum calcium level. So this is another, I would say, important marker for you to identify the fat embolism syndrome. Decreased red blood cell and platelet counts, and increased serum levels of lipids, of course, because it's fat embolism syndrome. Okay, so then uh, let's continue. These changes in blood values are poorly understood, but they aid in diagnosis of the condition. So I think we understand, right? We are nurses, we are all the time looking for the reasons, and we understand the whole laboratory findings, even the calcium, we were able to understand. Okay, FES, fat embolism syndrome, can result in respiratory failure to death, often from pulmonary edema. When the lungs are affected, the complication may be misdiagnosed as a pulmonary embolism from a blood clot, right? So we have the table here that is telling us the difference between fat embolism and blood clot embolism, right? Obstruction of the pulmonary or other organ vascular bed by fat globules. This is the fat embolism. This is the definition. And blood clot is obstruction of the pulmonary artery by a blood clot or clots. The origin in fat embolism, most from fractures of the lung bones, occurs usually within 48 hours of injury, and blood clot most often from deep vein thrombosis in the legs or pelvis and can occur anytime. So you can basically uh, read this part and conceptualize better all the definitions and the pathophysiology. Um, Let me continue with chronic complications of fracture, avascular necrosis, delayed bone healing, or chronic regional pain syndrome are later chronic complications of musculoskeletal trauma. Blood supply to the bone may be disrupted, causing decreased perfusion and death of bone tissue or avascular necrosis. So this problem is most often a complication of hip fracture or any fracture in which there is displacement of bone. Surgical repair of fractures also can cause necrosis because the hardware can interfere with circulation. Patients on long-term corticosteroid therapy such as prednisone are also at high risk for ischemic necrosis. And then we have the complex regional pain syndrome, formerly called reflex sympathetic dystrophy, is a poorly understood dysfunction of the central and peripheral nervous system that leads to severe persistent pain and other symptoms. We review a video, the CNS versus PNS, so we can better understand the sympathetic dystrophy, okay, and the dysfunction of the central and peripheral nervous system. So to what extent this condition is going to cause complex regional pain syndrome. I have provided again the link to the video that we review during the nervous system segment in this semester. Let me drink some water. Okay, so you can find the video in the supplemental material and you can review it as necessary. When we are talking complex regional pain syndrome is present, a triad of signs and symptoms is present, including abnormalities of the autonomic nervous system. That's why it's very important to review this video. Okay, changes in color, temperature, and sensitivity of skin over the affected area, excessive sweating, edema. That's abnormality of the autonomic nervous system. Okay, something that we cannot control. Motor symptoms, paresis, muscle spasm, loss of function, and let's remember that paresis is muscle weakness. And the third one is altered sensory perception symptoms, intense burning pain that becomes intractable. So now we are going to analyze the etiology and genetic risk. The primary cause of a fracture is trauma. That's the most common, right? From a motor vehicle crash or fall, especially in older adults. The trauma may be a direct blow to the bone or an indirect force from muscle contraction or pulling forces on the bone. So we have sports, vigorous exercise, and malnutrition are contributing factors. Bone diseases such as osteoporosis increase the risk for a fracture in older adults. And by definition, osteoporosis starts in minus 2.5 of your DEXA, right? Between minus 1.5 and minus 2.5 is considered osteopenia. Incidence and prevalence. Rib fracture are the most common type in the adult population. Femoral shaft fractures occur most often in young and middle-aged adults. And a shaft fracture is a type of broken bone that occurs along the length of the bone. That's the shaft fracture. And as you can see, there are many types of fracture types depending on the bone. So we are getting familiarized with all of them little by little. Fractures and aging. The incidence of proximal femur hip fractures is highest in older adults. Humeral fractures are also common in older adults. The older the person, usually the more proximal is the fracture. Okay, learn this. The older the person, usually the more proximal is the fracture. Middle age and older adults, especially women, have a high incidence of osteoporosis, which increases the risk for fragility fracture. We talk about this, osteoblast, estrogen, relationship. And let's review veteran health, musculoskeletal trauma in active military and veteran populations. So we are going to see strains, sprains, and stress fractures in lower extremities. Injuries in the lower back, in the lumbar spine region are also common, most likely caused by carrying heavy equipment and supplies. Our veterans. Thanks to the veterans, the veteran population. Okay, health promotion, disease prevention. Airbags have decreased the number of severe injuries and death, but they have increased the number of leg and ankle fractures, especially in older adults. So we have to teach patients about the risk for musculoskeletal injury, and we need to teach them about osteoporosis screening and self-management education, um, all the nutritional factors and activities that are high risk. We need to teach them about fall prevention, home safety, dangers of substance use and driving, proper use of helmet when riding bicycles, motorcycles, and other small motorized vehicles, devices like scooters and all these different type of bikes, motorcycles, bikes that are not bikes, scooters that look like bikes but are not motorcycles, you name it. The market is getting creative with this type of transportation. Remind individuals that if they smoke, they are more likely to have a fracture, experience severe pain from a musculoskeletal injury or surgery, and have a slower bone and tissue healing time than those who don't smoke. So right there, smoking is not good. You need to avoid. It's not to reduce, you need to avoid smoking. Okay. Assessment history. The patient with a new fracture typically reports moderate to severe pain. Delay the detailed interview for a nursing history until the patient is more comfortable. Then ask about the cause of the fracture. Of course, this is common sense. Incisional injuries, as from a knife wound and crush injuries, cause hemorrhage and decrease perfusion to major organs, right? Acceleration or deceleration injuries can cause direct trauma to the spleen, brain, and kidneys when these organs are moved from their fixed locations in the body. Sharing and friction damage tissue integrity and cause a high level of wound contamination. So we have to obtain a substance use history regardless of the patient age. Assess adults of all ages about opioid use for persistent pain before the fracture. This information is essential for developing a pain management plan for the patient. Ask about the patient occupation and recreational activities. This is part of the assessment. And let's get into physical assessment, signs and symptoms. The patient with a fracture often has trauma to other body systems because the fracture is going to um, cause damage in the soft tissue, maybe the muscles, right? Circulatory tissues, the nervous system. So, therefore, assess all major body system first for life-threatening cues, especially when patients have head, chest, and/or abdominal trauma. Some fractures can cause internal organ damage, resulting in hemorrhage. When a pelvic fracture is suspected, assess vital signs, skin color, and level of consciousness for indication of possible hemovolemic shock from internal blood loss. And this happens because the pelvic is a round bone, right? And holds too many nerves, and also the femoral. So that's why the femoral artery. So that's why we are thinking about hemorrhage. If this occurs and there is damage in the femoral, we have hypovolemic shock, right? The level of consciousness also is going to be affected depending on the nerves that are going to be affected in that area. Remember that there is one pelvic fracture, there is usually another fracture in the pelvis. Yes, because it's a round structure, as I explained before, even if it is a small or hairline. Check the urine for blood, which indicates possible damage to the urinary system, often the bladder. Yes, the bladder is related to the pelvic cavity. If the patient cannot void, suspect that the bladder or urethra has been damaged. Patients with severe or multiple fractures of the arm, legs, or pelvis have severe acute pain. Vertebral compression fractures that we are going to talk about later are also extremely painful. Patients with a fractured hip may have growing pain or pain referred to the back of the knee or lower back. Pain is usually caused by muscle spasm and edema that result from the fracture. So muscle spasms are common involuntary contraction. I am providing the definitions because whenever you go to NCLEX, you're going to find spasm, weakness, paresis, and you need to know the difference so you can answer properly, okay? So muscle spasm are common involuntary contractions of a muscle that can cause stiffness and tightness. Edema is the medical term for swelling caused by fluid trapped in your body tissues. Okay, nursing safety priority. This is good to know. NCLEX alert. Patients with one or more fractured ribs have severe pain. So the text is giving you an analysis of fracture in different areas, right? The hip, the femur. Right now they are talking about the ribs. So when the ribs are fractured, patient is going to have severe pain when they take deep breath. Okay, monitor respiratory status, which may be severely compromised from pain or pneumothorax, that's air in the pleural cavity. Assess the patient pain level and manage pain before continuing the physical assessment. So before they were talking about the pelvic fracture, they were talking about the risk of hypovolemic shock. Depending on the structure, your critical thinking has to evaluate what is the highest risk. For example, in the ribs, we are going to monitor respiratory status, right? For fractures of the shoulder, this is another type, another location, and upper arm, the physical assessment is best performed with the patient in a sitting or standing position. Shoulder and upper arm, so that the shoulder dropping or other abnormal position can be seen. The shoulder drooping or other abnormal position can be seen. Support the affected arm and flex the elbow to promote comfort during the assessment. And this is another criteria that it may seem logical, but at the moment of the assessment, at the moment of evaluation, many nurses, healthcare providers, they get nervous when they see the patient having a fracture, depending if it's open or closed, right? So they don't want to touch the patient as much because they don't want to increase the level of pain. But in this case, you have to be very delicate, right? And support the affected arm and flex the elbow to promote comfort during the assessment. Place the patient in a supine position for assessment of the legs and pelvis. We are going to another area right now. A patient with an impacted hip fracture may be able to walk for a short time after injury, although this is not recommended. And I've seen this. Patient with an impacted hip fracture, they were able to walk, and then suddenly the pain was, they couldn't even talk. When inspecting the site of a possible fracture, look for a change in bone alignment. That's a good physical assessment. The bone may appear deformed, a limb may be internally or externally rotated, and or one or more bones may also be dislocated out of their joint capsules. Observe for extremity shortening or a change in bone shape. Extremity shortening. This is very common with this type of fractures. If the skin is intact, we know it's a closed fracture. The area of the fracture may be ecchymotic, bruise. Okay, so I also include, because we need to be precise on the definition, the difference between hematoma and ecchymosis. When you receive report and they are going to describe the condition, the hematoma is defined as a solid swelling of clotted blood within the body tissues. Ecchymosis is a skin discoloration that results from bleeding underneath the skin and usually larger than 1 centimeter or 4 inches. That's ecchymosis. Okay, so hematoma is going to be a solid swelling. Then we have subcutaneous emphysema, the appearance of bubbles under the skin because of air trapping. That's subcutaneous emphysema. So right there we have many concepts: avascular necrosis, the fat embolism syndrome. We learn about the subcutaneous emphysema, the difference between paresis, muscle hematoma, ecchymosis, all this related to the musculoskeletal. Swelling at the fracture site is rapid and can result in marked neurovascular compromise. That's why neurovascular assessment is important as a result of decreased arterial perfusion. Gently perform a thorough neurovascular assessment and compare extremities, assess skin color, temperature, perception, sensory perception, mobility, pain, and pulses distal to the fracture site. If the fracture involves an extremity and the patient is not in severe pain, check the nails for capillary refill. Let me repeat. If the fracture involves an extremity and the patient is not in severe pain, check the nails for capillary refill. Throughout all this segment, that are 4 chapters of neuromuscular, the neurovascular assessment have been analyzed, described, listed in different ways. At this point, you should be able to do your neurovascular assessment, your 6P, okay, that I'm going to refresh again in a few minutes. Neurovascular assessment is very important. Now We know that we have to do our psychosocial assessment. We know that we have to consider culture and spirituality in terms of body image, sexuality, the support group of the patient, friends, religion. Let's see this table: best practice for patient safety and quality care assessment of neurovascular status in patients with musculoskeletal injury. And this is good to know. Maximum alert. Okay, so we're going to assess the skin color, temperature, movement, sensation, pulses, okay, and capillary refill, pain. So master this table. This is going to come in the NCLEX for sure. What else? Laboratory assessment. We are going to see hemoglobin and hematocrit levels that may often be low because of bleeding caused by the injury. We know that. We master our hematologic chapter, right? And then the erythrocyte sedimentation rate, with which measure inflammation, is going to be elevated, yes, which indicates the inspected inflammatory response. If the value and the white blood cell count increase during fracture healing, the patient may have a bone or soft tissue infection. Our WBCs are going to be high. During the healing stages, serum, calcium, and phosphorus levels may increase as the affected bone releases this element into the bone. While the healing stages is in process, there's going to be kind of, the body is going to try to make balance, and in this process is going to be imbalance, balance, imbalance. This is normal in the healing process. You're going to see changes of calcium and phosphorus in your blood work. Imaging assessment. We're going to start with x-rays. Then CT scan is useful in detecting fractures of complex structures such as the hip and the pelvis. It also identifies compression fractures of the spine. MRI is useful in determining the amount of soft tissue damage that may have occurred with the fracture. So the priority collaborative problems for patients with fractures include: we need to control the acute pain due to fractured bones. We need to decrease mobility due to pain, muscle spasm, and soft tissue damage. And we need to work on potential for neurovascular compromise due to impaired tissue perfusion. That's the main goal, right? The priority. So how we're going to manage the pain? We are going to look for a pain control between 2 to 3 on a pain scale of 0 to 10 after fracture reduction and immobilization. Let me repeat. So we want the pain to be between 2 to 3 after fracture reduction and immobilization. What interventions? A fracture can happen anywhere and may be accompanied by multiple injuries to vital organs or major vessels. So emergency care fracture, you first call 911 and assess for airway, breathing, and circulation, your ABCs or primary surgery, right? Then provide life-saving care. We know our CPR. We review this, and this is good to know, is needed. You're going to ensure circulation first, followed by airway and breathing. After a head-to-toe assessment, a short-term IV opioids is going to be in place. And then depending on the severity of the injury, NSAIDs and regional nerve blocks are going to be ordered. So this is in trauma, musculoskeletal fracture or injuries. This is the common protocol, right? So you start with a short-term IV opioids to manage pain. Then depending on the level of pain, the doctor may prescribe NSAIDs or regional nerve blocks. Then cardiac monitoring for patients who are older than 50 years is established before drug administration. They need to see how the heart is working. Fracture management begins with reduction and immobilization of the fracture while attending to continue pain assessment and management. Okay, so then we have another box, best practice for patient safety and quality care, emergency care of the patient with an extremity fracture. So we're going to assess the patient ABCs, right? Very quick head-to-toe assessment. We are going to remove the patient clothes if necessary to inspect the area, apply direct pressure on the area if there is bleeding, and pressure over the proximal artery nearest to the fracture. And I would say this is one of the most important steps. Apply direct pressure on the area if there is bleeding, and pressure over the proximal artery nearest to the fracture. It's very important, because you are preventing hypovolemic shock, bradycardia, tachycardia, I'm sorry, because when there is hypovolemic, you're going to have tachycardia. Remove regularly on the affected extremity in case of swelling. Keep the patient warm and in supine position. Check the neurovascular status of the area distal to the fracture, including temperature, color, sensation, blah, blah, blah. You know this. Immobilize the extremity by splinting. Include joints above and below the fracture. Recheck circulation after splinting. So all these steps are extremely important. Non-surgical management. Bone reduction or alignment of the bone ends for proper healing. Let me repeat. Bone reduction or realignment of the bone ends for proper healing may be accomplished by a closed method or an open surgical procedure. Non-surgical management includes closed reduction and immobilization with a bandage, splint, boot, or cast. Okay, this is the closed reduction approach. Okay, the primary healthcare provider selects the treatment method based on the type, location, and extent of the fracture. Yes, these interventions prevent further injury and reduce pain. So the primary nursing concern is assessment and prevention of neurovascular dysfunction or compromise. So nurses, students, neurovascular is your most important concept. You need to master this. You need to know your 6Ps, what to assess, how to assess neurovascular assessment. Assess and document the patient's neurovascular status every hour for the first 24 hours and every 1 to 4 hours thereafter. Right? Elevate the fracture extremity higher than the heart, and this is basically the protocol for most fractures in the extremities, right? And apply ice for the first 24 to 48 hours as needed to reduce edema. Okay, so that's good to know. NCLEX alert. Elevate the fracture extremity higher than the heart and apply ice for the first 24 to 48 hours as needed to reduce edema. And then close reduction and immobilization. That's one approach. And we're gonna watch the video. For example, we selected a reduction in a distal radius. So let's watch this video to have an idea how this is done.
This distal radius fracture is displaced, meaning that the bone fragments are not in place and well aligned. The fragment nearest the wrist is angled toward the back of the hand and the radius is shortened. If the fracture were allowed to heal this way, the wrist would not function normally, and so the fracture must be reduced or set. Pushing and pulling on a broken bone can be painful, and so some kind of anesthesia should be provided. One method is to inject a local anesthetic such as lidocaine into the fracture site. This is known as a hematoma block. The bone fragments can now be manipulated without causing so much pain. Traction is used to pull the radius out to length. The angled fragments can then be pushed into alignment with the rest of the radius. A cast or splint is applied to immobilize the fracture so it can heal. The cast is molded in such a way as to hold the fragments in place.
Excellent. So we see, for example, in this case, the location is very close to the median nerve, close to the carpal tunnel, right? Median nerve is the one that causes carpal tunnel. So in this case, you need to conduct your neurovascular assessment for carpal tunnel later, okay? What else? So manual pull or traction on the bone, the primary healthcare provider moves the bone ends so that they realign. Moderate sedation is used during this procedure. The nurse monitors the patient oxygen saturation and possible the end-tidal carbon dioxide, the ETCO, which is the goal is to keep it between 35 and 45, and this refers to the partial pressure of carbon dioxide at the end of expiration, right? And this is when the surgery, major surgery, is going to be performed, or in case of close reduction, right? It's not a major surgery, but it's going to be done, the manipulation, okay? And the respiratory rate falls to 10 breaths per minute. Wrap the patient's sternum and encourage bleeding. So let me repeat this because I think it's not clear. The nurse monitors the patient oxygen saturation, right? And possible the end-tidal carbon dioxide, which is the carbon dioxide pressure at the end of expiration, right? To ensure adequate rate and depth of respirations during the procedure. Okay, so if the ETCO becomes too low, below 30, and the respiratory rate falls to 10 breaths per minute, you can wrap the patient's sternum and encourage breathing. So you can help the patient to recover close to normal status, right? Normal ranges. An X-ray confirms that the bone ends are approximately aligned before the bone is immobilized. Okay, that's good. Here we have some walking boots of various sizes and types. Splints and orthopedic boot shoes for certain areas of the body, such as the scapula, the shoulder and clavicle, collarbone. A commercial immobilizer may be used to keep the bone in place during healing. Because upper extremity bones do not bear weight, splints may be sufficient to keep bone fragments in place for a closed fracture. And splints for lower extremities are also custom fitted using flexible materials and held in place with elastic bandage. When possible, splints are preferred over casts, and I really want you to remember this. When possible, splints are preferred over casts to prevent the complication that can occur with castings. Splints also allow room for extremity swelling without causing decreased arterial perfusion. Again, splints also allow room for extremity swelling without causing decreased arterial perfusion. So that's why splints are preferred over casts. For foot or toe fractures, orthopedic shoes may be used. For ankle and the lower part of the leg, padded orthopedic boots supported by multiple Velcro straps to hold the boot in place may be used. Let's talk now about casts. For more complex fractures or fractures of the lower extremity, the primary healthcare provider or orthopedic technician may apply a cast to hold bone fragments in place after reduction. And we already know what is the reduction, right? Is the realignment. A cast may be applied for correction of deformities or for prevention of deformities, dosing in some patients with rheumatoid arthritis. Fiberglass, a waterproof synthetic casting material, is used most often for fracture immobilization, fiberglass. And then fiberglass can dry and become rigid within minutes and decrease the risk for impaired tissue integrity. Hold that thought there. So fiberglass can become rigid in minutes, okay? Plaster is used much less often today. Plaster used to be the preferred method for cast, right? What happened with plaster that it takes at least 24 hours to dry, depending on the size and the location. So that's why fiberglass right now is used most often. If tissue integrity under the cast is impaired, the nurse is gonna cut a window in the cast so that the wound can be observed and cared for. And tape or elastic bandage wrap may be used to keep the window in place. So they are all the time, you should be all the time assessing what's going on under the cast, right? When a patient has an arm cast, teach the patient to elevate the arm above the heart to reduce swelling. This above the heart is used in many procedures and in many protocols in the musculoskeletal traumas, right? The hand should be higher than the heart. Ice may be prescribed for the first 24 to 48 hours. When the patient is walking or standing, the arm is supported with a sling placed around the neck to alleviate fatigue caused by the weight of the cast. Leg cast allows mobility and requires the patient to use ambulatory aids such as crutches or a walker. A cast, shoe, sandal, or boot that attaches to the foot, or a rubber walking pad attached to the sole of the cast assists in ambulation if vein wearing is allowed and helps prevent damage to the cast. So the nursing intervention is to teach patient to elevate the affected leg on several pillows to reduce swelling and to apply ice for the first 24 hours or as prescribed. So this is another safety priority, nursing safety priority. That's good to know. NCLEX alert. Check to ensure that any type of cast is not too tight, and frequently monitor and document, again, neurovascular status, usually every hour for the first 24 hours, which is another protocol that is repeated in many of these procedures. After application, if the patient is hospitalized, you should be able to insert a finger between the cast and the skin. Okay, that's good to know. Teach the patient to apply ice for the first 24 to 36 hours to reduce swelling and inflammation. Okay, so inspect the cast at least once every 8 to 12 hours for drainage, alignment, and feed. And here comes another that's good to know. Immediately report to the primary PCP provider any sudden increases in the amount of drainage or change in the integrity of the cast. After swelling decreases, it is not uncommon for the cast to become too loose and need replacement. That's why you need to check the status of the cast after swelling decreases. It's not uncommon for the cast to become loose and need replacement. I think you're going to see this concept somewhere soon. Assess for other complications resulting from casting that can be serious and life-threatening, such as infection, circulation impairment, and peripheral nerve damage. Infection. can result from impaired tissue integrity under the cast pressure necrosis. So the patient typically reports a very painful hot spot under the cast, and the cast may feel warmer in the affected area. Can you believe that? The cast may feel warmer. Teach the patient or family to smell the area for mustiness or an unpleasant odor that would indicate infected material. Teach the patient to never put anything down inside the cast, such as hanger or pencil, to scratch and itch, because this action can cause significant skin damage. And believe it or not, young adults are doing this even more than kids. Circulation impairment causing decreased perfusion and peripheral nerve damage can result from tightness of the cast. Teach the patient to assess for circulation at least daily, checking for numbness, increased pain, and the ability to move the area distal to the extremity. Remind patients to wiggle their toes and move them up and down. That's the way they can check for circulation impairment. So the patient with a cast may be immobilized for a prolonged period, we know that, depending on the extent of the fracture and the type of the cast. In this case, assess for complications of decreased mobility, such as skin breakdown, pneumonia, atelectasis, venous thromboembolism, and constipation. And atelectasis is the collapse of a lung or part of the lung, also known as lobe. It happens when tinier sacs within the lung, called alveoli, right, lose air. So lung anatomy, there is here a link that I have provided for this. And prevention for atelectasis is deep breathing exercises, incentive spirometry, early ambulation, chest physiotherapy, such as percussion or vibration to mobilize secretion, proper positioning, put the patient in a forward position to prevent alveolar collapse, oxygen therapy, but first get the prescription, right? You don't put the oxygen in the level you want, and assisted coughing. So let me see if we can watch this video. And this is NCLEX alert. I want you to know by heart what are the steps for preventions of atelectasis. Okay, this is very important, extremely important for all nursing care. Okay.
Your lungs are two spongy organs in your chest. The left lung is divided into two lobes, or sections, and the right lung has 3 lobes. When you breathe in, air enters your nose or mouth and passes into your trachea or windpipe. At the carina, the trachea divides into 2 bronchi, then branches into smaller bronchioles. The bronchioles end in tiny air sacs, or alveoli. Here, the oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale. Your lungs are encased by pleura, a thin membrane that protects them and helps them slide back and forth as you breathe in and out. Underneath your lungs is the diaphragm, a smooth, thin muscle that helps your lungs expand and contract as you breathe. Your lungs are connected to small collections of immune system cells called lymph nodes by way of lymphatic vessels. You have groups of these lymph nodes near your lungs, above your collarbones, and behind your breastbone, as well as in other parts of your body. The lymphatic vessels carry bacteria, cancer cells, and other unhealthy material away from your lungs and other organs in a clear fluid called lymph. Lymph nodes filter this material out of the lymph. Lung cancers most commonly start in the bronchi, but they can also begin in the trachea, bronchioles, or alveoli.
Thank you very much. So I know this explanation does not belong to the musculoskeletal, but since they are mentioning atelectasis, and that's one of the most important concepts in nursing, and you need to master your nursing intervention. That's why I'm mentioning this, and we are reviewing these concepts, right? So NCLEX examination challenge. First question. The nurse is assessing a client who sustained a right display closed ankle fracture as a result of falling. Displays closed ankle fracture. What would be the nurse priority assessment related to the fracture? And monitoring neurovascular status is the answer. You can find the right answers for the NCLEX examination challenge and the mastery questions in your electronic evolve resources. Okay, so this is coming from that resource, student resources. So we're going to stop here, and then we are coming back with more of this chapter, and we're going to start analyzing traction. Okay, thank you.